Welcome, I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Joining me today to discuss the recent 2023 match results for emergency medicine and their impact is Dr. Robert McNamara, Professor and Chair of Emergency Medicine at Temple University and also past President of the American Academy of Emergency Medicine. Also joining me today is Dr. Amy Ho, Senior Vice President of Clinical Informatics and Analytics at Integrative Emergency Services in Dallas, Texas. Welcome to both of you. Thanks so much for joining me today.
Thanks so much for having us.
So I want to, begin our discussion on the high number of unmatched emergency medicine spots, a little over 550 in 2023, up from 219 in 2022. And so, the concern is that even a year prior, there was only a handful, I think 13 or 14 unmatched positions. Bob, I want to begin with you and really talk about the reasons for the increase and what you see as really the main factors behind this increase in spots that were unmatched this year.
Yeah, I think it's a twofold issue. So first off, we didn't have a great year last year. I mean, the SOAP filled most of the spots, but we also had a historically high number until this year, of course, of unmatched spots last year. So, the best source would be talk to the students, right? We don't have them here, but I think most are settling on sort of a twofold thing. One is just the raw economics. Am I going to have a job? That's the multifactorial. Two key issues there. One is 2 years ago, the class graduating in the midst of the pandemic had difficulty finding jobs. That word filtered out. That was because ED volumes went down. Places weren't sure they wanted to hire. And then on top of that, there was a study published by ASAP that said we're going to have an oversupply coming 2030 of 9,600 excess emergency physicians. And then the second thing, which to me is way more concerning, is the burnout. We're leading in burnout, 65%. Most recent survey, right? 5% above everybody else. I believe there's many factors contributing to that, some of which have existed for a long time, like the boarding problem, that's getting worse again. But as you know me, with the American Academy, I think the corporate influence has really been a problem. People see that, they feel loss of autonomy in their jobs. They're concerned that corporations will replace them with non-physicians. So I think it's a twofold thing.
Exactly. Amy, I want to bring you into this. A tweet of yours hones in on what Dr. McNamara is talking about. Really, that this situation is actually not unique to emergency medicine, and it has happened with family medicine, psychiatry, and pediatrics. So I'll let you elaborate on this and, expand a little bit on what your thoughts are, in these primary care, sort of safety net specialties.
There's a couple issues here. One is absolutely that you see the safety net category of specialties going down in popularity. EM is obviously the one that we're all in. So that's the one that we, I think, are focusing most on. But family medicine, pediatrics going down is also highly, highly, highly concerning. I think this reflects a couple things. I think one is just frankly a generation of medical students that understand work-life balance. And I think they were forced into that because as you saw COVID evolve, this was the first time that I think doctors had to balance their work life with literally their personal lives. Like go back to March, February, April of 2020.
Right.
And there was a huge, huge concern when these kids were in medical school that, ER doctors, frontline doctors were literally bringing COVID back to their families, potentially getting like elderly parents that live with them sick, potentially sacrificing their own life. And I think that forced this generation of trainees to think about, what does work mean to me? And the conclusion is that they don't want to be martyrs for the job, which I think is what medicine universally felt like. So you take this category of people that understand work-life balance and you put them into choosing specialties. So I think Dr. McNamara really kind of comments on this already, but you have two pieces, right? There's the benefit, there's what you want to do with your life, obviously the reimbursement, the compensation of it, and what you're willing to sacrifice. And with everything going on in medicine, there's a high amount of burnout, mostly because of moral injury, like systemic failings in the healthcare system. And then you also have this substantial drop in reimbursement and pay. Like CMS is cutting RVU reimbursements right now. Health insurers are getting more powerful in actually denying claims so that providers aren't getting paid. And at the same time, there's a scope creep issue of, of APPs getting, just traded in one for one for doctors by CMGs that don't really understand the difference between a doctor and an APP. All this put together makes these safety net specialties highly unattractive to medical students, which is unfortunate because that's really where we have needs in our healthcare system.
Yeah, I completely agree with you. These are very important points you make. Bob, certainly the APP issue has been front and center with the task force, and the concern that 1 in 5 patients in this factoring of the surplus, will be seen or were to be seen by an APP in some sense. So, this happened in the House of Anesthesia, 40 years ago, where there was a lack of spots for many years. And then they self-corrected themselves by increasing the number of spots over the years. But, the question is, we need to work with our APPs because they're valuable to our team. And so what do you see as the way and the sort of the pathway to incorporate them in the next several decades?
The factors are a little different in emergency medicine. The use of non-physician providers, their recent article published in the last couple of months showed some information from the industry, from Envision, from American Physician Partners, where they basically said, we want to use the cheapest resource to get the job done. Like, we'll gladly replace you with a physician if it's going to be more for the bottom line. And we have to understand, this is private equity that's running a large swath of emergency medicine. Their duty is to the investor, not to the patient. So we've allowed this influence into our specialty. And there's the great concern that they're just going to replace you unless you can show that you're cost beneficial. Now, there's a whole movement, as you're aware, Physicians for Patient Protection, which is, really pushing back on the whole idea. To me, we've all made position statements. The academy has, the college has. Those are all, paper tigers, right? It's the person who owns the contract that decides the staffing. So we really, I believe, need to hone down on making sure it's the physicians that decide the mix that's going to see the patients. Most of the people that apply emergency medicine, and I'm saying, they're not in it for the money. They have a strong sense of social justice. They know they're going to make a decent dollar, but I really think probably the main two figures are, will I have a job and will I survive in it? Will I burn out in a corporate world where I'm trying to serve the neediest of society and they're pushing me for metrics?
Right. It's that lack of autonomy, I think that really tugs at us, what's happened. And so, the issue of the right fit for medical students over issues of such as prestige, that exist and ability to make money, there has to be a reset in my mind. And it's a cultural shift, I think, in teaching medical students really to understand themselves and where their passions are.
Yeah, I agree with that. I think medicine is an incredibly noble profession, no matter how you slice it, no matter what specialty you're in. Like, my belief is that you should pick something to do with your life that really drives you. I think there's definitely realities, which is what we're talking about here, of what you need to do to sustain your life, what you need to do to sustain your lifestyle, your debt, etc. But I think, again, culturally, this is a group of young people, of trainees, medical students, et cetera, that understand the work-life balance. And so when you look at some of the things that make it less balanced, i.e. compensation, I actually totally agree with Dr. McNamara. I don't think ER doctors are going into it for the money. I think that they have obvious needs and they need to make a career. But I think there is a feeling of more insult when reimbursement cuts. I don't think it's actually the dollar amount that's getting us. It's the feeling that, hey, we went through a pandemic. We work harder than we ever did before. We are doing a lot of just acrobatics to make things work. I think a great example of this is waiting room medicine. The ER has largely shoved out into the waiting room and come up with processes to see patients out there to address issues like boarding that are interdisciplinary and that are long-term solutions that we're working on. But in the meantime, like we've taken on the short-term patch to make this safe to be there for our patients. And I think when you balance that with the feeling of, hey, we're unappreciated, that the CMS like doesn't recognize this, I think that's where you start to run into the dissatisfaction. Again, I agree. I don't think it's the actual dollar amount. And I think you see this with family medicine and pediatrics, like their administrative burden is going up. Those are some of the lower paid specialties. They're squeezed into 6 to 10 minute visits for very complicated patients. They're charting after work for hours. Like they're feeling the squeeze and the lack of appreciation. And where you see that field going is actually interesting, right? Like you see a lot of trends about DPC, like direct primary care, where they're trying to cut out middlemen so that they can treat patients the way they want to treat patients. Like, unfortunately, in that model, it doesn't necessarily address like the underserved and patients who can't fall into that business model. But you see a lot of market forces shaping how doctors are trying to deliver care.
I want to just go back to the issue of boarding, because a lot of this stems from essentially a workforce shortage. We're talking about nurses upstairs in the hospital where we can't send our patients that are admitted upstairs. And so we're recovering from this very slowly. The issue of locums replacing, a large number of team-based care up on floors, ICUs, even in the emergency department. That has played a role, not only in cohesiveness, but in terms of outcomes, patient outcomes. And so, I think that looking to address boarding, which we thought we had a little bit of a handle on, maybe in the last 5 years or so, but now this is really cascaded. And so, attracting the students we want to attract, but having to play waiting room medicine and dealing with boarding are two of the biggest things that I think they look at.
Right. Yeah, I agree with you. We all know emergency medicine is an inherently stressful specialty. It's not just what we see, violence, the opioid epidemic, the 24/7, the nights, the weekends, and the holidays. So we have that baseline. You're walking into it, it's going to be stressful. And it doesn't matter what the salary is. If you feel somebody's taking advantage of you, whether it's the contract holder who you think is taking money out of your pocket, or CMS, which is not appreciating you, or the hospital, which is not giving you the resources, that's going to erode your core. So boarding is a huge crisis. And, you have a specialty that's afraid to speak up as well. We're afraid to speak up for fear of losing our jobs. And that's a very uncomfortable situation. You want to stand up and advocate about boarding. I complain about boarding all the time. I speak to the CEO of the hospital. I just sent him a note 2 days ago when I worked a Monday shift and we were getting admissions upstairs in less than 2 hours, which was like remarkable. Like, good job, let's keep this going. But most places we can't do that. It creates that situation where you're doing waiting room medicine. The same patients are staying there shift after shift. You need to see the new patient to be educated, right, as a student or resident. And it's not just in the hospital, right? The nursing homes can't take patients because they don't have staff. The hospitals say, well, we're backed up. We can't clear the beds because the other places, they've lost workforce.
So how do you incentivize the system, in other words, to work to solve this problem?
Yeah, I actually think this is a really interesting discussion, especially when we're talking about boarding and waiting room medicine. I actually deviate a little bit from Dr. McNamara's point on here. I absolutely think boarding is a huge issue. I think that there are advocacy efforts between ACEP, AAEM, et cetera, to share stories of boarding to try to help people understand why this is such a large issue. And I think we know that it's heavily interdisciplinary, right? There's the question of why do Americans need the ER so much? That's a safety net question. That's a healthcare access question. Once you're in the hospital, there's questions of absolutely staffing for nursing, but also lab for radiology. There's also questions of, where do patients that are in the hospital go, i.e. SNFs, long-term care? What are the insurance approvals for moving patients there? What's the speech therapy, OT, PT that needs to happen? So highly interdisciplinary. I think where I deviate from Dr. McNamara is I feel like holding patients hostage for us to stamp our feet and say, this is an issue, is not the solution. Like, I don't think us refusing to go into the waiting room is the right solution. I think us as physicians need to lead the processes that can make waiting room medicine a little bit more safe. And the reason I say that is, you look at everything we do in ER, right? If the glide scope is broken, I'm ready with DL. If there is no bougie, like maybe I'm ready to use a fiber optic or digitally intubate or something like that. Like, we have many fail safes of taking very imperfect situations and making them manageable. And that's how I see waiting room medicine, because I think we should create processes to make it manageable so that we can see patients while we're working on the long-term solution. And I think the long-term solution is absolutely where we need to drive forward. But without us being willing and able and putting our full capacity behind keeping patients safe now, I think that we're really just complaining. Like, we have to be part of the solution, and we have to entrench ourselves really deeply, especially in that short-term solution, because we're so close to the patient.
So the problem is we're enablers, right? We do everything we can for our patients. That's the nature of emergency medicine. So we are willing to see people in the waiting room, in chairs, in hallways. We will do that because that's part of the moral fiber of an emergency physician. The problem is people know that, right? They take advantage of that and, compare us to other specialties. Would they accept, hey, we need you to do the operation, not in the OR, but here in the hallway? It's not going to happen. So it's a balance. I mean, obviously, we're all committed to the patient first, but there has to be, an awakening. There was a great New England Journal of Medicine editorial. I know Gabe Kellman was one of the authors, which really outlined the problem. The longer waits, the more the boarding, the higher the morbidity, the mortality. So it's a self-perpetuating situation. I don't really know the solution. We need a public outcry. We need somebody to say, this isn't right. Now, that can happen in your individual institution. All right. We've been able to, with the strength of our department and our school, to argue and continually press the issue, work with other colleagues. I actually rounded on the inpatient units with some other chairs to say, how can we make things go faster up here? That's not what you get if you're working in a community hospital where your boss is private equity. You're not going to be able to press that button. And it's creating a big problem in our specialty.
But penalizing hospitals that have longer boarding times in the ED, I mean, that, certainly there's been readmission criteria from CMS that have looked at CHF and other outcomes and looking at, readmissions. Why not create a system where boarding is made, very front and center? And we have a national task force to address this and penalize systems that can't accommodate and adjust to this, ongoing issue.
Yeah, I mean, I think it's actually a really interesting idea. I think there's certainly a point to bringing it front and center and making it a metric. I think there is a danger there, though, that when you incentivize it with like a CMS metric or something, that you come up with the wrong solutions. Like, remember that this is a very, very interdisciplinary question, like even societal question of what do we do with patients that are debilitated from like an acute stroke or something that requires an inpatient hospitalization. Like, what do we do with them if they have no family, if they have no insurance? It opens up a lot of questions of, what kind of safety net is there in our social fabric? And a lot of that's, I mean, honestly, legislative. So I think putting in just a new metric maybe isn't the solution without forcing a lot of those conversations and bills really about how do we create support in society for these patients that end up being quite long-term stayers in the hospital, because that will improve a lot of throughput. Same thing for like workforce shortages. Like, what can we do here to help incentivize nursing? Should you cap locums pay? Because, nursing and physicians sometimes too will go chase way higher dollars in locums. So I think absolutely make it front and center, get some information, get some data out there so we know what's there. But maybe just throwing like a metric and an incentive pay behind that or a penalty may or may not have some downstream effects as people learn to just game that system.
But when it's linked to patient outcomes, doesn't that really, that really is the bottom line here. when you look at the outcomes, we know are adverse with longer boarding times. But getting back to the whole crux of, what does 2024 hold for the match? And 25 and 26. Looking at the surplus, Dr. Marco's article, are we headed on a trajectory where we're going to see 1,000 unmatched spots, do you believe, going forward?
Yeah, my opinion is honestly some of the issues we talked about here, the moral injury, the systemic issues, the reimbursement and the pay and this culture of work-life balance. I don't think it's going to get better, especially not in time for 2024. And again, those medical students still live through COVID. I think as long as the trainees have gone through this COVID time, it'll continue to worsen without any significant interventions. Again, multidisciplinary, I think, from the specialty societies, from reimbursement, right, from hospitals, et cetera. So unfortunately, I think we might increase our unmatched spots and or not fill them in the SOAP.
Right. And the attrition rate, certainly will be going up, I would imagine. Things are just not, from what I can tell, improving.
Well, I mean, you're mentioning attrition rate. So after the Marco study, the Gettle study came out. Marco's study was based upon a 3% attrition rate. The Gettle study said, we actually have a 5% attrition rate. So it throws off all the figures of that projected 9,600. The unfortunate thing is, wait a second, we got a 5% attrition rate? I mean, back when I was younger, we were worried that it was 1.5% attrition. Mm-hmm. And that's a reflection of what we're seeing of the problems within the specialty, which, we have to wake up and we have to say we're the highest in burnout. The professional societies need to look at the issues. Obviously I have my biases. I think a large part of it is the feeling taken advantage of by corporate entities and whatnot. Emergency medicine in its purest form is the greatest specialty in my view still. I've had a great career, but I've not been in a situation where I felt like I was taken advantage of or I couldn't advocate for my patients. Now, we know there's going to be more residency slots next year, right? Because we're continuing to improve programs. I don't think we're going to get much worse, but I don't think we're going to get much better. The pool itself is my greatest concern, that the best and the brightest, and I think it's already happened this year, have decided to go somewhere else. And, we're filling huge numbers with the SOAP. Some of them are going to be real high quality people who, they didn't match an ENT or whatever, but in love with emergency medicine, they didn't apply to us first. And you kind of got to be in love with the specialty these days to survive in it. There's a lot of jobs because our attrition rate is high. It's diluted the pool. There were data in the past, 20% were in the top 10% of the class, 2/3 were in the top 1/3 of the class, the best and the brightest choosing EM. Right. And I don't know what it's going to be now. And I also know if you're filling in the SOAP, you're not getting people whose first choice was emergency medicine. That's going to affect the patients because these are, it's going to be difficult for those people to bring their best person to the bedside. I fell into the specialty through the SOAP and I don't really like it.
Yeah, I actually take a slightly more optimistic view. I still think that the match is probably going to get worse next year for emergency medicine, but I actually think it's not that we're not getting the best and brightest. I think the people we are getting are intensely passionate about EM despite all of the issues. And what that means is you get a class that has a lot of diversity, a lot of different backgrounds, especially ones in social equity, because they're really interested in this idea of being the safety net. They know that ER is absolutely a safety net specialty, one that's being really rained on in a lot of ways because of things going on in the world. And I think even in the SOAP, you're getting maybe people that weren't, the best scores or the best GPAs, but let's be honest, those were never great indicators of how good, how compassionate of a bedside doctor you are. So what I actually think is happening, even with the SOAP, is that the diversity we are bringing in backgrounds for the specialty will really help the specialty move towards an area of advocacy. And for that, I'm extremely optimistic about the new generation who, again, understands work, understands life, understands the issues in healthcare, when they're getting in versus some older classes, I think, that went in because of that and maybe didn't understand the complexities of what is the healthcare system. And for that, I am extremely thrilled to meet the new class.
Yeah. Well, I want to thank both of you for a really lively discussion, important points that both of you brought up. Thank you again. I really appreciate it.